Peter Smith, a 65-year-old male patient with end-stage renal disease, has been undergoing regular hemodialysis for 4 years 3 times a week. His past medical history includes diabetes mellitus type 2, hypertension, increased cholesterol, atrial fibrillation, and chronic obstructive pulmonary disease. After 1 hour of initiation of his regular hemodialysis treatment, he called the nurse with complaints of difficulty breathing, chest pain, and general malaise.
Hello, is this Dr. Tan from Nephrology Department?
Yes, this is Dr. Tan speaking.
Yes, good morning, Doc. My name is Gezelle Tangalin, a registered nurse from Toronto General Hospital working at the dialysis unit. Yes, I am calling because I have a patient here, Mr. Peter Smith, a 65-year-old male patient who is in the unit today, January 18, 2024, for his regular hemodialysis treatment. However, after 1 hour of initiation of his hemodialysis, he suddenly complains of difficulty breathing, chest pain, and general malaise. The patient had a primary diagnosis of end-stage renal disease. He had been undergoing hemodialysis 3 times a week for 4 years now. He also had a history of diabetic type 2, hypertension, increased cholesterol, atrial fibrillation, and COPD. The patient had no known allergies. And also, his current orders for ultrafiltration gross volume are 2.3 liters due to his UF net of 2 kilograms and saline brain stack of 300 mils. He had a good radiocephalic AV fistula axis, and he is tolerating well his blood flow rate of 350 mils per minute with a dialysate temperature of 36.5 centigrade, not until he had experienced these symptoms. Upon checking on the patient, blood pressure is 170/100, pulse rate is 102, and irregular respiration is 24, temperature is 37.9, and SATs are 86% with wet crackles upon auscultation. Also, his heart sounds are regular and normal. His skin has normal turgor, appears sweaty, and feels warm. He has chest pain with a 9/10 pain scale, non-radiating to other areas. Also, upon assessing the patient lines, it has been noted that there is a kink in the hemodialysis tubing located just after the pump segment, which causes back pressure, which is why the pressure alarm are not triggered. Also, the blood in the tubing was noted to be bright red and frothy. I did a 12-lead ECG, which shows sinus tachycardia. We collected his blood to check his CBC, electrolytes, and Groupen screen for possible blood transfusion. Hemoglobin level shows that there is a decreased number from 84 to 65 grams per deciliter based on his results before treatment, and also potassium level was increased from 4.2 to 5.3 millimoles per liter. With these findings, I suspected the patient is having acute hemolysis. Therefore, I initially discontinued the hemodialysis treatment right away without blood restitution, as it may cause severe hyperkalemia by infusing potassium released from hemolyzed erythrocytes. Also, I connected the patient from a cardiac monitor to closely monitor the patient's vital signs. I also suggest if we could put an order to repeat electrolytes and monitor his ECG to check for any signs of hyperkalemia, since his potassium level was elevated right after the incident. I also provided him some oxygen therapy. I put him on 6-liter nasal prongs just to make sure his oxygen level is greater than 88%, since he had a history of COPD. With the hemoglobin result, I would suggest giving him 1 unit of packed RBC, then recheck his CBC after transfusion. A possible transfer to the intensive care unit might also be necessary to monitor the patient closely, and once he is stable, then we can restart his hemodialysis treatment.
Yes, I will put the orders for the repeat blood work to monitor his electrolytes. I'll also put a 1 unit of POC RBC to transfuse, and please recheck his hemoglobin level after 1 to 2 hours after transfusion. I will go there now to assess if the patient needs transfer to the ICU. If there are any changes in status, please notify me immediately. And if needed, we can treat him too with extracorporeal cytokine absorber to reduce free hemoglobin and erythrocytes and cytoplasmic molecules in the bloodstream.
Right. Thanks, Doc. I'll see you soon. Thank you. Have a good day. Bye.
Thank you.
Lately, a 41-year-old female patient has been on automated peritoneal dialysis for 8 months caused by end-stage renal disease. Her PD regimen includes a 2-liter fill volume for 5 cycles over 9 hours. She uses 2 bags of 1.5% 5-liter dialysis bag during each treatment. Past medical history includes diabetes mellitus, hypertension, gout, and anxiety. She presented herself to the emergency department due to constant abdominal pain, abdominal tenderness, fever, nausea, and vomiting, and cloudy effluent fluid evident in her last PD last night.
Hello, is this Dr. Vera?
Yes, this is Dr. Vera.
Hi, doctor. My name is Giselle. I'm a registered nurse from Scarborough General Hospital working at the emergency department. I am calling because a patient presented herself to the unit who is on nightly automated peritoneal dialysis with suspected peritonitis. Ms. Cindy Lee, a 41-year-old female, is in the unit today, January 25, 2024, with complaints of constant abdominal pain, abdominal tenderness, fever, nausea, and vomiting, and a cloudy effluent fluid evident in her last peritoneal dialysis last night. The patient's primary diagnosis is end-stage renal disease. Her past medical history includes diabetes mellitus, hypertension, gout, and anxiety. She also had no known allergies. She is currently on automated peritoneal dialysis treatment for 8 months now, and her current peritoneal dialysis regimen includes a 2-liter fill volume for 5 cycles over 9 hours. She uses 2 bags of 1.5% 5 liters dialysis bag during each treatment. Upon checking on the patient, blood pressure shows 140/96, pulse rate is 110 and regular, respiration 25, temperature 38.9, and SATs of 92%. Her heart sounds are normal. She had a pain scale of 8/10 on her abdomen and was tender on palpation. She also had 1 episode of vomiting early this morning and still feels nauseous. Her peritoneal exit site appears dry and reddened without any noticeable discharges. Her skin feels warm to touch, and as per the patient, a cloudy effluent fluid is noted during her last treatment last night. With these findings, I would suspect patient is having peritonitis. Therefore, I would suggest to do culture and sensitivities by swabbing the PD exit site. Also, prescribing the patient with Tylenol for pain and ondansetron or diphenhydramine for nausea is also beneficial. Based on hospital rules and policies, we can start the patient on peritonitis protocol, which includes flushing the effluent fluid with a 1.5% 2-liter dialysis bag, which can be done 3 times until the fluid becomes clear. Also, we can start the patient on intraperitoneal antibiotic of ceftazidime 1.5 gram and cefazolin 1.5 gram in a 1.5% 2-liter dialysis bag, which can be done for 6 hours with manual drain during the day. I would also suggest to put orders for nystatin 5 ml every 6 hours to prevent fungal infection. Also, is it possible to put a referral to a peritoneal dialysis educator to teach her about proper hand washing, proper machine setup, and proper exit site dressing change and shower technique? The patient should also be educated that her treatment room must be clean and free of breaths. Otherwise, the patient can resume his nightly automated peritoneal dialysis treatment regularly.
Yes, please do the swab first before giving the antibiotics. I'll put the orders for pain and nausea medications. And please monitor the patient and let me know if there's a change in status. I will be there to assess the patient after finishing my rounds.
Right. Thanks, Doc.
Thank you.